devices that may be part of the BRAIN initiative do funnel through my branch. I'll get into that a little bit later. So I'm going to be talking to you today about some best practices for navigating the pre-submission process with FDA. So I've kind of focused this primarily on the pre-submission process, but as I'll get into and as hopefully you'll be able to see, a lot of things that I talk about here can easily be applied to other types of submissions as well, whether it be an IDE or a marketing application. So I'm going to start out giving a little bit of an organizational and a regulatory overview. I'll just go through some very brief things on that. I won't get into too much detail. Following that, I'm going to get into an overview of the pre-submission program itself, going over some of the common issues that we tend to see and some of the best practices, really trying to help you understand what we're looking for and how you can give us the best submission possible so we can give you the best feedback possible. And finally, I'll close it out by just going over some additional resources and programs that are available to you. To the organizational overview, within CDRH, there are a number of different offices. And so all of you as individuals who will be working through IDEs, pre-subs, that sort of thing, you're going to be dealing primarily with the Office of Device Evaluation. That's where I am. There are a number of different divisions within the Office of Device Evaluation. Ours, as I mentioned, is the Division of Neurological and Physical Medicine Devices. There are a number of others for things like orthopedics, cardiovascular, and things like that. So within DNP&D, we have three branches, one being the Neurostimulation Devices branch. That is the branch for which I am chief. The Neurosurgical and Neurointerventional Devices branch, and finally the Physical Medicine and Neurotherapeutic Devices branch. With it, we have a number of different types of technologies. We have deep brain stimulation, we deal with spinal cord stimulation, vagus stimulation, other types of external stimulation devices for pain and psychiatric disorders, and then we also have, even though it doesn't appear in the name of our branch, we also have non-EEG-based neurodiagnostic devices. And so the one thing that I want to point out here when it comes to types of stimulation devices that we have, they're really for the neurological disorders and conditions. So we're not talking about devices that are intended to, say, restore function or maybe related to other types of disease conditions. So vagus nerve stimulation for cardiac uses, for example, that would be reviewed by the cardiovascular division. With a surgical and neurointerventional devices branch, they have a number of different things. They have neurothrombectomy devices, flow diverting devices, aneurysm coils, CSF shunts, other types of cerebrovascular guide wires, catheters, cranial materials, and other sealants. It's all of the intravascular devices that are used in the head primarily. Then finally, the Physical Medicine and Neurotherapeutic Devices branch, they have all of the brain-computer interface devices, as well as powered exoskeletons, functional electrical stimulation devices, electromyography devices, and EEG-based neurodiagnostic devices. So the reason why I wanted to bring this up, as I'll get into later, is if you have a sense for what devices fall into which branch, that can help give you an idea of who you may want to contact if you have some administrative or types of simple questions. A little bit about the regulatory overview. So as some of you may know, some of you may not know, there are three different classes of devices. These are defined in the Code of Federal Regulations in 21 CFR 8, and that, I'm sorry for the typo, it's 860.3. And the different classifications are based on the level of regulatory control that's needed to provide, quote unquote, a reasonable assurance of safety and effectiveness. I will do that later, but it does entail some specific principles that may not be readily apparent. So it's not the purpose of today's talk, but I can certainly get into that if a question comes up. So start Class 1. Class 1 are the lowest risk. They are subject to only general controls that are authorized by the Food, Drug, and Cosmetic Act. Good example of that is toothbrushes. Class 2 is general controls alone are insufficient to provide a reasonable assurance of its safety and effectiveness, and there is sufficient information to establish that special controls will be able to provide a reasonable assurance of safety and effectiveness. When it comes to types of devices that you encounter, transcranial magnetic stimulation is a good example of that. With Class 3 devices, only are general controls alone insufficient. There's also not enough information to establish special controls that would provide a reasonable assurance of safety and effectiveness. Good example of a Class 3 device would be deep brain stimulation. There are regulatory marketing submissions that are associated with each one of these. Class 3, that's going to be your pre-market approval application. Class 2 is going to be a 510K, also known as a pre-market notification, provided that the intended use and the technology are similar to something that's already classified. And then finally, we have de novos, and this is for devices that aren't comparable enough to something that's already on the market. So this is a new device regulation and will typically, but not always, be Class 2. There is a possibility if something goes through the de novo process that it could wind up as Class 1. So I'm seeing here that there are some questions already funneling in, so I believe that we'll be saving those for the end of the presentation during the Q&A, but please feel free to keep sending those along. And so moving on. Another marketing submission I want to just briefly touch on is the Humanitarian device exemption. So this is considered a marketing application. It's fairly similar to a PMA. There are some differences. And so to give you an idea of the background for that, the purpose of the HDE process is to help encourage the discovery and the use of devices that are intended to benefit patients in the treatment or diagnosis of diseases or conditions that are manifested in fewer than 4,000 individuals in the United States per year. So we're fairly uncommon things. So that's the landscape of the various marketing submissions that you might encounter. Now I'm going to get into an overview of the pre-submission program itself and go through, as I said, some of the common issues that we see and some best practices that you can put into place. So the guidance, if you are not aware of it, I have a link here. This is the request for feedback on medical device submissions, the pre-submission program, and meetings with Food and Drug Administration staff. If you are unable to see slides right now and you don't have a copy of the guidance, your best bet is to go to whatever search engine you prefer, type in FDA pre-submission guidance, and it will probably, hopefully, take you to the right place. The guide covers multiple types of interactions. Today, we're going to focus on the pre-submission. There really are a number of different things that are outlined in the guidance. It's actually quite lengthy. I think it's about nearly 60 pages long. Frame for review. This is something that comes up quite a bit. Per the FDA strives to hold a meeting, if you request one, within 75 to 90 days of when we acknowledge that the pre-submission has been received. If you do request a meeting, we will provide written feedback about 3 days in advance of the scheduled date of the meeting. So with any pre-submission that you submit, you're going to get written feedback. The real question is, do you want feedback plus written feedback plus a meeting, or just written feedback itself? It's really up to you. And whether it's a telecon, an in-person meeting, or some of both, because maybe you have some people on your team who can't make it into an in-person meeting, we can certainly accommodate that. You should plan to meet with us or receive that written feedback within 75 to 90 days after receipt. And that's really due to the workload considerations of the review staff. As much as we would love to focus solely on each individual submission that is before us, each person in the branch, and this for pretty much every branch in the division and probably throughout the office as well, each person generally has about 10 things going on at any given time. And so unfortunately, we're unable to devote sufficient time to a particular file and get it done very, very rapidly. So really make sure you budget your time accordingly, and really plan on the 90 days for having the meeting and getting the written feedback. And what I like to tell people is that plan on 90 or 75 to 90, anything, if we can accommodate anything earlier than that, we will, but you shouldn't plan for that. There are reasons to engage as early as you can. Interactions allow potential issues to be identified a lot earlier than they might otherwise be, and then we can help work through them with you as appropriate. This is particularly useful if there are concerns related to novel technology, novel types of testing, other things like that. Notice to engage as early as you can is that if needed, if there are some outstanding questions, for example, that are present at the end of a pre-submission review, or if you think about some other things, you can submit a supplement to get additional feedback. That typically means another 75 to 90 days, unless it's a very, very focused question. But that is an option that's available to you. One at the very, very beginning, and unfortunately, I see this far too many times, e-copy. This has been in place for a while now. However, it still comes up as an issue. You really need to make sure that you comply with the e-copy guidance. And again, if you can't see the slides, if you just search CDRH e-copy guidance, that will probably get you to the right place. Pre-submissions are one of those types that do need to have an e-copy. And the one thing to keep in mind is that your submission will not officially be logged in. The review clock will not start until we receive valid e-copy. I won't even know that it exists, and I therefore won't be able to assign it to a reviewer until we receive a valid e-copy. So I posted the e-copy email address here. If you have questions related to that, email address is also within guidance if you need to go and find it later. As far as concerned with a pre-submission, it's fairly straightforward. You have the cover letter, background information, which has whatever information you want us to review, device description, vendor animal testing protocols, clinical study protocols, and a set of specific questions that you really want us to focus our effort on for the purposes of the pre-submission. And as you should think, the questions should be based on the information that's provided in the submission. One of the big common issue, other than e-copy, as far as pre-submissions, and really a lot of submissions in general is concerned, is that not enough information is provided up front. So I just wanted to give you a little bit of background information here. So we ran an analysis of a number of investigational device exemptions, IDEs. And so we looked at some letters of about a year, and we showed that the area that generated the most questions when it came to the letters was the general category of device description. And it covers everything from what the device is, what the device does, instructions for use, the hazard analysis. It was a very, very broad category. There were a number of other things as well. This are in a way the biggest one. So we have similar issues across other submission types. This has a big impact on the review process. If we have enough information to understand the device, to understand what it is you're trying to do, we end up getting a lot of questions. And so providing complete responses to those questions takes time. And in the case of things such as IDEs or marketing applications, it can extend the overall length of the review. As much as possible, we like to avoid that. And so it's really helpful and really necessary to try and provide as much information as you can up front. So there are things that you can do. The first, realize that you as the applicant know the most about your submission and not FDA. You've done this, whatever project that it is, probably for a while. At least, I would say on the order of months, perhaps even longer. If we get an IDE from you, we have 30 days in which to evaluate all of that information. Even pre-submission, we have 75 days to view and evaluate what could be months, if not years, worth of work. So the more you explain your thought processes when you submit a pre-submission or an IDE or a marketing application, the more they can focus on the substance of the submission and give you better feedback. It's also in the existing landscape. So there are different ways to do this. Search for and review applicable guidance documents and standards, if there are any, such as biocompatibility, if you're not using an approved device, or if you are using an approved device in a manner that's fairly from the way it was approved, or software, for example. So there's a guidance for software contained in medical devices. That's something else. Search engine, CRH, software guidance will probably take you to the right place. And the point that it's really helpful for you to explain the relationship between what you're proposing compared to what's been done in the past. Again, it's about helping us follow your thought process and understand why it is you're doing why you're doing what you're doing, and how you got to that point. So there's a search engine, if you will, for guidance documents that's available on FDA's website, and a number of different guidance documents. However, they may not be one that's applicable to your particular situation. There's also a search database for the standards that we recognize. When it comes to information, there are some best practices. So, for example, it's okay to err on the side of including what you think may be more information than we would need in order to review things. One thing I would say is that make sure that it's organized and that it's easy to follow. If you cite literature articles, please provide copies in the submission. It's much easier to have them right there on hand so we can go through them. There is such a thing as too much information. I'll just give you some really quick examples, and I still understand where I'm going with that. So circuit diagrams, far detailed for us to be looking at either in a pre-submission or some other type of application. If absolutely do need something like that, we'll ask for it. Same would go for lines of software code. Not something that needs to be included in a submission to us unless we specifically ask for it. I don't ever seen that. Finally, copy of your entire grant. There may be sections of the grant that you want to include as part of your application, whether it's a pre-submission IDE or whatever. Do we need to see the entire grant as part of as one component of your application? No. For background information, try as hard as you can to avoid assumptions. So, for example, unless there is an applicable guidance, standards, or some other regulatory precedent that you're aware of and you can cite, you need to identify the most appropriate approach for your needs and justify it. Again, it's allowing us to see and understand how you got to where you are. You may be doing something different from the way something may have been done in the past. That's okay. We'll evaluate it. The way to avoid questions is to help us understand how you got to that point. Why is the way you're doing it the best approach for your particular situation? Example of that, not every animal study needs a non-human primate model. There's some other model and some other protocol that may be better suited to your particular situation. The onus is really on you to come up with a proposal and bring it to us and say, here's the approach that we want to take. Here's why we think it's the best approach to take. What are you about that? What are your concerns with it? And we'll evaluate that and we'll give you feedback on that. specific questions, there are a couple of issues that we see, and I'd say they tend to fall into a couple of different categories. So this is as related to the topic I just talked about, not providing your own proposal for us to review. So a good example of that, what animal model should we use? Well, I don't know. How large should the sample size be? I don't know. Really, behind the pre-submission process in particular, because that's the one that deals with specific questions like this, is that you're giving us a proposal and you want us to evaluate it. So we're not going to come up with the right model for you to use. We'll provide comments on the proposal you put forward. General category is wanting us to review data. So does FDA have any comments on the non-clinical test results? Or what do you think about the safety and effectiveness data that we collected in our feasibility study? Or does data demonstrate a reasonable assurance of safety and effectiveness? The idea behind the pre-sub is not to make what is essentially the type of decision or the type, or provide the type of recommendation that we would be doing in a marketing application. The idea is really to talk about the types of things that you want to do, the types of testing that you plan to do, and how to design your studies in such a way as that they should provide the highest quality data possible. So when it comes to specific questions, they should build on the background information that you've provided. Good question. What concerns do you have with our proposed animal model? Are the proposed sample size calculation method and the related elements of the statistical analysis plan appropriate for the proposed clinical study? Things like that. Or are the endpoint, what concerns do you have about the endpoints that we've selected for our clinical protocol? Things like that. Those are examples of good questions. To just a few other available resources and programs that are out there on our website, which admittedly is a little hard to navigate at times, but if you go to fda.gov/medical devices, you'd hopefully be able to find these three things: CDRH Learn, Device, and then CDRH New. So I'll just go through those briefly. Advice is really comprehensive regulatory assistance, and I do mean comprehensive. It do an overview of and access to all of the regulations that govern all of our processes. There are also links to medical device databases for clearances, approvals, and more. And so you can look up 510s that have been cleared, PMAs that have been approved, look up so for PMAs, for example, you can see the summary of safety and effectiveness that just kind of outlines our entire rationale for approving something. It also includes how-tos for what to include in various submission types, whether it be IDE, 510K, PMA, whatever. So it's a very good resource to use if you don't have a lot of experience with a lot of these processes. And so I've included the link down here at the bottom of the slide. Learn is a little bit different. It's, to quote what we have on the website, it's an innovative multimedia catalog of online educational modules intended to provide information about medical device laws, regulations, and policies that's comprehensive, interactive, and easily accessible. This one, probably even more so than Device Advice, can be helpful if you're new to FDA regulatory processes. And that's something that's available on our website. We have CDRH New, which provides updates on guidance documents, approved devices, and other regulatory actions. This thing that can be helpful to access and stay updated on, and you can sign up for an email subscription. You can sign up for RSS feeds. If you want to know when things come up that may be affecting you, there may not always be something that's affecting you. It could be, but there could be guidance documents, there could be recognized standards, other things like that that may impact what you're doing, and so it can be a good idea to stay on top of those things. And they come on a fairly frequent basis. Finally, not sure who to talk to. Going back to the few initial slides that I had about the types of devices that are in each one of our branches. If you have simple basic questions, particularly from an administrative perspective, and you don't already have a contact within the branch, start with the branch chief, start with me. Dr. Lin Zhang is the branch chief for NIH, the Neurointerventional and Neurosurgical Devices branch, and Dr. Vivek Pinto is the acting branch chief for the Physical Medicine and Neurotherapeutic Devices branch. Reach out to one of them, and we'll try, or me, and we'll try and address your question. And you have a slightly more specific question. You might realize it's more specific, but it is more detailed. We will likely tell you that it's more appropriately addressed as part of a pre-sub itself or some other type of application, and we can give you guidance as far as that's concerned. For me. So my contact information is here again, and I'd like to thank NIH for inviting me today to give this webinar, and I think I will turn it back over to Stephanie to figure out how we deal with questions.
Great, so much. So Tim, I believe have people been sending you questions specifically, like you privately?
Have.
Okay, we have a couple that have also been sent to us privately. So what I think we're going to do is we're going to send those to you through the chat room as well, if it works. And that way you'll have them all compiled. Does that sound good?
Good.
Great. So I will start sending you those, and you can feel free to start addressing some of those questions. And obviously, if there's something that's more appropriate for us, we're happy to answer those as well.
Okay. All right, so let's just start things off here. Our group uses stimulating peripheral nerve cuffs for enabling sensation on prosthetic arms. Do these fall under my branch or the Neurotherapeutic Devices branch? Because that is for sensation on prosthetic arms, that would fall under the Physical Medicine and Neurotherapeutic Devices branch. So I'm going to bring up the slide with every contact info to make it a little bit easier on you. Let's see here. Would a cortical visual prosthesis device go through my branch? If visual prosthesis IDEs, and this may be something that, and Stephanie, I think that would it be okay, there are some things that I need to follow up on. Could I send you the information afterwards?
Absolutely. I think that's a great idea. Obviously, not everything can, we do have to check on a couple of things. So certainly that might be something that we need to verify, and we will get back to you on that, the individual who asked that question.
All right. So I believe that a cortical visual prosthesis would likely, and this is one I have to check on, but it would likely go through vision of ophthalmic and ear, nose, and throat devices. They had the Argus 2 8E. I believe those would go through that division as opposed to ours. Discuss the early feasibility program for obtaining approval for a clinical trial. I'll be brief one. So there's early feasibility and there's early feasibility. And without too vague and nebulous about that, there's early feasibility when you have something that's been used before and maybe you're just tweaking something slightly, but you're doing a fairly small study. That may be considered early feasibility in practice. It doesn't really involve extra, either your part or ours. If you're talking about something where it's an entirely novel device and you're looking at doing an early feasibility study for it, that's a little bit different. And that's when you get into something like the device evaluation strategy and other things. So I don't want to get too far into that because I think that could take up a lot of time. But I can send Stephanie some links to some hopefully very helpful early feasibility information. All right, here. What level of design controls are expected to be implemented for IDE devices? Is this level of control verified by FDA prior to the IDE approval and or clinical trial, and if so, how? Okay, so that's we don't actually hear that often. There is a, and again, this is a link that I can provide to Stephanie. There's information on our website. And when it comes to IDE devices are subject to design controls. They're from all the quality system regulations, except for design controls. And as far as that's concerned, without getting into too much detail, you are expected to comply with the design controls. Those generally aren't submitted in an IDE. You should have them in your records. You should have them on hand should you be inspected or audited by, say, our bioresearch monitoring counterparts over in the Office of Compliance. That's about all I have to say on that. So you are expected to comply with design controls. Are we necessarily going to verify that, quote unquote, as part of the review of the IDE? Not necessarily. Question. FDA ODE IDE application reviewers. Are there generally expected best practices for particular situations? For example, a novel device on the selection of animal models, for example, large animal versus small animals. I think perfect reason to come in with a pre-submission to discuss it. And it's really a matter of what do you think is the best approach that fits your particular needs. If there's no guidance document out there, there's standard. If there's nothing really out there as far as the regulatory communication that says what we expect, then it's really up to you to say, here's what we propose to do, here's why we think it's the best approach. It's better to do that as a pre-submission than as part of IDE, because that will be able to give, we can be more interactive, we can have a meeting about it, we can discuss our concerns and our feedback with you. If not in an IDE, sure, the time frame is shorter. You're talking about 30 days for us to give you feedback, as opposed to 75 to 90. You're not necessarily getting the same amount, the same degree of interaction as you would in a pre-sub. And again, you're not really able to ask the specific questions in the IDE that you would in a pre-sub. Is it possible to apply for a device that is not for production, but rather a limited number of devices for a specific experiment that IRB does not process? Entirely sure where. So I'm going to interpret what I believe to be the intent of that question, and if that was your question, feel free to message me or Matt if I was incorrect. So there are you can certainly send in an IDE for something that's not going to be commercialized. In fact, we have seen that in the past plenty of times. You are still have to provide all the necessary information in order for us to be able to approve the IDE. Does every device that comes in as an IDE have to be one that will eventually be commercialized? No. All right. I have FDA links about early feasibility de novo device studies. Is there a particular individual within FDA who can provide more information? And de novo are separate things. If you're talking about early feasibility studies, best bet is to go to the guidance is available. CDRH early feasibility study guidance in your favorite search engine. Guidance that comes out will have a contact person associated with it. And so, if you have questions specific to that guidance, please that individual and they should be able to help you. If you don't get anywhere with them and it's related to devices that are under our purview in my branch or division, feel free to contact me. And I'll try and help you out. As far as Novo is concerned, I'm trying to remember if the draft guidance is still out there in the wild. I would have to check on that. Let's see. I'm working on a piece of device and would like clarification about the submission/oversight process. I understand that if one can demonstrate minimal risk, the institution's IRB can oversee the study, but otherwise, non-significant risk devices have dual IRB oversight. I wrote the protocol to address the latter, even though we are hoping to obtain minimal risk designation. Is this a correct approach, or should I reach out to you before I submit to the IRB? When it comes to determining whether something is significant risk or non-significant risk, or in other cases, basic physiological research, you're going to be talking to your IRB first. They can and should be making the first cut. So if he says that something is non-significant risk, that's a cut. You don't need to come to us. If the IRB says that something is significant risk, you can either come to us and submit an IDE, and that'll be that, or you can send in risk determination request. So this is actually another type of interaction that's covered in the pre-submission guidance. And what that does is it allows you to submit information about your protocol and some basic information about your device, and we evaluate it for the purpose of determining whether we with the IRB that it's significant risk, or if we think it's actually not significant risk, or if we think it might be basic physiological research. So that gets you an approval, the IDE, so it does not mean approve your study. All it does is it allows us to make assessment as to whether it's significant risk and we would need to see an IDE, or if it's not significant risk or basic physiological research and we don't. So as part of the IDE process, let's say you don't submit a risk determination request. Let's say you just send in an IDE. As part of that, we will evaluate it to see whether we think it could be non-significant risk or basic physiological research. And if that were to be the case, and we would determine that it is NSR or BPR, to you a letter that reflects that. All right. Circuits are often critical for safe driving of stimulation electrodes. Why would FDA not routinely want to see circuit schematics and diagrams? Great, and thank you for that one. At kind of a high level, what we're looking at is the output. We want that the device does what it says it's supposed to do. And so what we're going to focus on is the testing that you do, generally more so than the real nuts and bolts of the actual design. So we're generally not going to look at schematics. And the reason is that the test provided should reflect that your device has been tested in all the conditions that we would want it tested, and it's providing the output that it's supposed to, that you're addressing failure modes and things like that. You've tested to appropriate CEMI standards, things like that. It's the same thing kind of applies with like software code, for example. So I absolutely agree, circuit designs are critical for safe driving of simulation electrodes. Does that necessarily mean we do or want to start seeing circuit schematics and diagrams? No. Next, we heard that the sheet model in ISO 10993 is the de facto required large animal model for devices implanted in the human brain. Is this, or can any animal model be reasonably justified for the IDE? I think the first time during this webinar use my go-to, it depends. We accept whichever animal model you propose. It depends on whether you can sufficiently justify that it is appropriate and it's the best one that's available. So this is the type of thing that is good to try and hash out during a pre-submission, rather than waiting until an IDE and you're probably farther along in the process than you'd like to be, only to hear, well, we don't buy your argument. So I think that is a great time to come in with a pre-submission. Anytime you're thinking about what sort of animal model you should be using, really a pre-submission is the best time to go through that. And does it for all of the questions that have come to either me privately. Oh, there's another one.
So I was going to say, before you start, I was also going to make two comments. One is that we will be making the slides available once Tim has had a chance to take a look at those and make sure he's with those. We will be making those slides available, so all those who could not get to slides for technical reasons, we will be making those available to you. This is being recorded. The second thing is, if for whatever reason you come up with a question later, or your question has not been addressed, or you want to have a follow-up, you can send an email to the BRAIN email address, the same email address that you used to register, and a BRAIN FOA at NIH.gov email address. Again, that's the same email address you used to register. And we will try to address those and certainly pass those on to Tim and make sure those get addressed. So,
thank you. So it's got one final question, and then I think that does, unless there's a sudden flood of other questions that come in. Will the FDA provide guidance, albeit non-official, before the pre-IDE? I'm entirely sure what that means. Oh, more coming in. So, vision is really time when we're giving you that helpful feedback on directions that we recommend or things we think you should consider. That really is that quote unquote unofficial. It's official in the sense that it's coming from FDA, and we try and make sure that we're not changing our positions later unless there's a clear reason to do so. That really is the time, though. There's not really anything before that. So the device we want to use is currently commercially available in Europe. Do we need an IDE to implant it here in the U.S.? on details that I'm missing, the answer to that would be yes. So there are a couple of distinctions about that, and this is the type of basic question that I'm comfortable just addressing via email or over the phone. There's a device and it's approved. Let's say it's approved by FDA here in this country, and you're using it on for the same indications for use, and you're not really doing anything different as far as the intended use is concerned, or putting it in a different spot, that sort of thing. You need an IDE for that. So if you have questions about that, please let me know, and I can go into that with you. If it's something that's not approved, it states. And so, as in this example, if it's approved in Europe and you want to use it here in this country and implant it into patients, and you're collecting safety and effectiveness data, then you're going to need an IDE for it. What is the best process to follow if we want general feedback from FDA to support our funding proposal, but don't have enough formal information to request a pre-sub? Well, you may think you don't necessarily have enough formal information to request a pre-sub. You might actually have enough information. To be these enormous, gargantuan efforts, they can be fairly limited in scope. Let's say that you only have enough information on say a particular type of testing, and you want to make sure that this is a good approach that you're taking. You can send in a pre-sub that's limited to that type of testing, and we'll provide feedback on that. And that'll be. You can submit a pre-sub that's more all-encompassing, more comprehensive, that includes a clinical protocol, non-clinical protocols, and things like that. It's to you, but we can and do and will review pre-subs that are fairly limited in scope. More than one pre-sub meeting or mission. Yes, as long as it doesn't continue indefinitely, and as long as we're not having these pre-subs and meetings to address the same issue over and over and over. And there is I did get into this because it's not really pertinent to the rest of the topic information. We do have an acceptance review that we conduct within the first 14 days after we receive your pre-submission. Make sure that you've got the basic information that we need to review it. And if we identified that maybe we were in one of those situations where it was just like the 20th time we were seeing something, or the 20th time that we were seeing the same issue from somebody, we'd let you know at that point. Gotten out ahead of all of the questions now.
That's great, Tim. I think we don't have any more on our side either. So that concludes this webinar today. I want to thank Tim again for coming and talking, as well as answering the questions that people had. I think they were all really great questions. And again, if you have any specific questions, you can certainly send them to the brain-foa@nih.gov, and we will be able to address those. That's the same email address that you used to register for the webinar, and we're happy to address those. So thank you, Tim, and we will again be making these slides available. Thank you,
Stephanie.
And I also want to add, we just got a quick question, and yes, the recording will also be available as well.